Thanks, Dan, for this wonderful introduction. Good afternoon, everyone. Hopefully, we'll have enough time to talk about several aspects of sickle cell disease today. So this talk is entitled Treating Sickle Cell Disease, Novel Therapies for Old Challenges. And that's just to start underscoring how long it's been that we know sickle cell disease and how not as far as we would like to we've come in treating this disease. These are my disclosures, and in particular I have to highlight my conflict of interest with Agios. It's a company who's developing new treatments for sickle cell disease. Two of them I'm going to mention in this talk. So for learning objectives, I chose that at the end of this presentation, attendees should be able to recognize the mechanisms involved in the pathophysiology of sickle cell disease, associate different therapies with their respective targets in that pathophysiology, and identify shortcomings of current therapies in sickle cell disease. So hopefully by the end of this talk, I'll be able to at least give a good overview of what we have and what is possibly coming. And I can't help but start showing these maps, which are almost classic at this point, showing how sickle cell disease has a worldwide distribution, but also that it overlaps quite strikingly with the distribution of malaria. And one thing that I like to highlight when I show these maps is that malaria has a distribution up to this century. We definitely haven't controlled malaria yet, and we can still see how sickle cell disease prevalence and malaria overlap, specifically when we're talking about severe malaria. In any case, I also like to highlight that hemoglobin disorders are ubiquitous the way they are right now because of people migrating all over the world. So therefore, we should not assume that someone must or must not have a hemoglobin disorder depending on their origin. This is a very, very brief epidemiology of sickle cell disease because I think, first, we can't forget that over 100,000 African Americans live with sickle cell disease these days all over this country. But the thing that I like people to remember, if anything, about how sickle cell disease presents clinically is that it is a disease that shortens your lifespan very significantly. This is the latest data I was able to pull from the literature, and it shows that the average life expectancy for a sickle cell disease patient is still 22 years shorter than that of patients of the general U.S. population, and even shorter than the an African American population matched to the same patients, so without sickle cell disease. So again, this is a disease that has a huge burden on patients. It shortens the lifespan, and I have to highlight that during their lifetime, it's not exactly a pleasant life to live with sickle cell disease. So let me start by talking about the pathophysiology of sickle cell disease. And I apologize to anyone who is tired of hearing about this, but I just want to make sure that we get all the details and everyone on the same page. So as you can see, this is a representation of what a sickle cell disease pathophysiology looked like maybe, let's say, in the 20th century. We know that it's caused by this point mutation in the beta globin gene. It generates the abnormal hemoglobin S. This hemoglobin S has this particular property of polymerizing under conditions of hypoxia and acidosis. And that generates the polymers that sickle the cells. We know sickled red blood cells are stickier, so they tend to adhere to endothelial cells and therefore generate vaso-occlusion. So the way we used to think about sickle cell disease is basically red cells getting deformed and clogging the blood circulation. We now recognize that this was a simplification of how the pathophysiology of the disease is, and we know that on top of having the sickling of the red cells causing hemolysis and anemia, and on top of having adherence of the red cells to the endothelial cells causing vaso-occlusion, causing the pain crisis that are typical for the disease, as well as end organ damage, we recognize that other cells and other mechanisms are involved. So first, nitric oxide depletion, and we recognize that It's the release of hemoglobin and heme in circulation that contributes to nitric oxide depletion in this disease, as well as other hemolytic anemias. On top of a lot of oxidative stress are very important in the pathophysiology of sickle cell disease. And also, neutrophils and platelets are very much engaged in the vaso-occlusive process. So I'm representing there one neutrophil. They're believed to be the initiators of the vaso-occlusive crisis. So they're sometimes the first to come to the site where the patient will have pain. And of course, they're much larger than sickled red blood cells, so they will contribute a lot to the vaso-occlusive process. On top of that, I am representing with the letter P the P-selectin that is expressed by both endothelial cells and certain circulating blood cells, such as platelets. We recognize that P-selectin is very important in terms of intercellular adhesion. So we know now that vaso-occlusion in sickle cell disease doesn't only rely on the sickling of the red cells, but also on recruitment of neutrophils, recruitment of platelets, and the way the interaction between cells, including blood cells with endothelial cells, generates oxidative stress, endothelial dysfunction, which eventually leads to end organ damage. So this is a very busy figure to show that sickle cell disease is a progressive and systemic disease. You can find nearly all organs in the body be affected by sickle cell disease to some degree. And obviously, I don't intend to go over this whole slide. I can only highlight that we worry particularly about cardiac complications, pulmonary complications, and chronic kidney disease, as you will see in the following slides. But of course, these patients struggle with several manifestations that will lead to a lot of burdens, such as chronic leg ulcers, on top of all the damage to the bones. What happens with sickle cell disease patients as they age, and why is their lifespan so short, as I mentioned earlier? And this is an interesting graph showing the incidence or the prevalence of certain complications among patients with sickle cell disease and how they change over time. And we start with, during like the first 10 years of life, many patients will manifest, for example, pneumonia or acute chest syndrome, almost 50% of patients. And as patients age, more patients will manifest this kind of complication. Acute chest syndrome is a big thing because it is among the most important causes of death. But we're also looking at asthma, gallstones, chronic kidney disease, and avascular necrosis. And we see that while pneumonia, acute chest, and gallstones will increase early in life, when we move into the teens and 20-year-olds and finally young adults and adults, we see that avascular necrosis becomes progressively more of a problem, affecting up to 20% of patients before age 50, which is definitely not the same epidemiology for osteoarthritis, for example, that affects the same joints. And then we can see that chronic kidney disease becomes a huge problem as these patients reach older age. So again, we're talking about a disease that leads to shortened lifespan, and during this lifetime, they develop several chronic debilitating complications. What do patients die from? And there's not a lot of literature about exactly what the main causes of death are in sickle cell patients, but the largest study and the most recent one I could find is this one, and it's showing clearly in the red bars that circulatory complications are still the main cause of death in sickle cell disease patients. If you lump it up with pulmonary complications, infectious complications, most of these patients will die of such complications. Differently from what we might imagine, it's not necessarily a vaso-occlusive crisis that just goes wrong, but many times it starts with a vaso-occlusive crisis going very wrong. Overall, how sick are sickle cell disease patients, and why are we struggling so much to find treatment options for them? This is a comparison of the burden of disease, and sickle cell disease is right in the middle of this chart, showing that patients on dialysis probably have like the poorest quality of life of the diseases considered there: asthma, patients with cancer on treatment, or cystic fibrosis. But keep in mind that 1/3 of these patients will report pain every single day of their lives. And they have a worse quality of life. If you have an association between sickle cell disease and end-stage renal disease, and as I showed on the earlier slides, it is a common complication later in life. So we can easily assume that these patients have a poor or the poorest quality of life as they age. So what determines how severely ill someone gets? And I can't help but talk about all the variety of sickling disorders that we have recognized. What they share in common is they all have at least one allele expressing the sickle cell mutation. But if you look, for example, at the upper sickling disorders, those are the most severe ones. Of course, homozygotes for sickle hemoglobin are expected to be the most severe, not very different from what we see in sickle beta 0 thalassemia. And then as we go downwards, we'll see that depending on the combination of hemoglobins these patients carry, they may have less sickling, less hemolytic anemia, all the way to the mildest form of sickling disorder, which is sickle hereditary persistence of fetal hemoglobin. So it will be always paramount to have a hemoglobin electrophoresis to determine what the genotype of the patient is, just because that way we can have a good idea of how severely ill they will be. Of course, there's a spectrum to this. This is as mild, so sickle HPFH is as mild as sickle cell disease can be. Most commonly, we're associating a sickle hemoglobin mutation with a deletion that causes increased production of fetal hemoglobin. And differently from what people might think, sickle HPFH is not totally benign. We know from patient descriptions that these patients can have splenomegaly, they can even develop osteonecrosis and joint pain. They have been described to have retinopathy, the same way we see in several other sickling disorders. So even though it sounds really good on paper, having 27 to 36% of fetal hemoglobin the way these patients usually have is not necessarily a cure. It's most certainly better than what we see in homozygotes, but definitely not a cure. And most of these patients will have some degree of hemolysis and therefore some degree of anemia. The other spectrum, and I can't say that it's a sickling disorder, but I like to mention, is sickle cell trait. Because first, it's very prevalent in our population. And second, we tend to think that, oh, it's a trait, it won't cause anything. And I like people to be aware that even though these patients have no anemia, no hemolysis, they will still have a higher risk of developing chronic kidney disease, proteinuria. There is a defined association between sickle cell trait and pulmonary embolism and exertional rhabdomyolysis that became very prominent in the press a few years ago because of NFL players developing that kind of complication. There is a low association with very dramatic specific complications such as splenic infarction, papillary necrosis, and even medullary renal carcinoma. But most of as far as the renal medullary carcinoma, I've only seen a few of those, and every single time I've seen it, the pathologist already knew that the patient had sickle cell trait. So there's a very good association. There is no association, contrary to what we would expect, with DVT, for example, or stroke, or even heart failure and growth delay. And one thing that I like to mention, which is kind of a clinical pearl really, is the risk of patients with sickle cell trait developing acute glaucoma if they have some eye trauma. The sickling of the red cells inside the eye can prevent normal circulation of fluids inside. Back to the pathophysiology and how we treat sickle cell disease. So how did we treat sickle cell disease, let's say, in the 1980s? And of course, we quickly recognized that sickle cell crises require hydration, require pain medication, and if it's associated with an infection, definitely antibiotics. And then transfusions were also a natural path towards treatment, since these patients are running low hemoglobins, they're getting symptomatic of that anemia, and also we want to dilute the hemoglobin in the expectation that it will have less sickling. We also recognized in the 1980s that transplant was curative for sickle cell disease, so it's not exactly a new idea. Only at that time, the very first patient was treated for leukemia and happened to cure both diseases. What did we learn about transfusion for treatment for sickle cell disease? First, there are very clear indications these days. I think stroke and acute chest syndrome with symptomatic anemia are very classic indications for transfusion. Hepatic sequestration and other liver complications are also very commonly an indication for transfusion. Multi-system organ failure will definitely not improve without transfusions. And then those acute anemias that we see mostly in childhood, such as a splenic sequestration, aplastic crisis, or symptomatic anemia, usually with a very low hemoglobin under 6, are all classic indications of transfusion. About the symptomatic anemia, I like to highlight that there is no one number that we're chasing for sickle cell disease patients, or for any patient, as a matter of fact, in terms of transfusion. But you will see that our thresholds for transfusion in sickle cell disease patients tend to be lower than we usually see for other conditions. And it has a lot to do with, first, avoiding hyperviscosity, and second, the fact that hemoglobin S per se can deliver oxygen much more easily. It has a much lower affinity for oxygen. So typically, patients won't get symptomatic unless it's a sudden drop or just a very large drop from their baseline hemoglobin. And finally, there is at least one big study showing that preoperative anemia for general anesthesia benefits from transfusion for a hemoglobin of 10. What are the challenges that we find with transfusion? We found out that it doesn't matter how much you transfuse these patients, you can't abort a vaso-occlusive crisis by doing that. And particularly for the uncomplicated vaso-occlusive crisis, it's completely useless. It doesn't treat priapism. It doesn't treat leg ulcers. And it's not a good choice for recurrent splenic sequestration. We also don't know exactly what goal we're chasing. The 30% of hemoglobin S that we chase is based obviously on all the studies for stroke and primary and secondary prevention of stroke. But we don't know that 30% is a magical number that would treat other complications in sickle cell disease. We also don't know for how long we should be transfusing patients that did have stroke or some serious complication. And transfusions come with iron overload, which is a whole talk on its own. I will just highlight that in sickle cell disease patients in particular, we see that iron accumulates preferentially in the liver and very rarely goes to the pancreas or the heart, as we see in other transfusion-dependent anemias. And finally, alloimmunization is a big issue in sickle cell disease patients. It's been long recognized that these patients are more susceptible to alloimmunization. It has to do with donor versus recipient incompatibility, obviously, but we also recognize that there are immune mechanisms that predispose certain patients with sickle cell disease to be more easily alloimmunized. Well, I'll talk briefly about transplant because I think we still have a lot to go over. As I said, the first transplant was performed in the 80s, and so far only 3,000 patients or so have been transplanted around the world. And that's mainly because only 14% of patients will have a matched sibling as a donor. There are also several hurdles that are trying to be overcome, such as a high incidence of graft failure in such transplants. Using matched or mismatched donors definitely plays a role. And GVHD is always a problem when we're transplanting a benign disorder. So if the patient is transplanted before age 16, the rates of GVHD are around 12–14%, while when they're adults, or over 16 to be more precise, they can reach above 20%. So it's definitely an undesirable complication of transplant. The guidelines for transplantation in sickle cell disease have been very recently published, and last month to be exact. And we see that neurologic injury such as stroke or silent infarct is definitely an indication to consider transplant from a matched sibling so far, and also failure to respond or inadequate response to standard of care. Recurrent acute chest syndrome is one type of failure. Some will consider having one end organ damage or several vaso-occlusive crises a year. That's still up for discussion, what exactly is failure or inadequate response. But in any case, we need to understand what this standard of care really is. Just so you have an idea, I'm not going to go over this whole slide, but overall survival after transplant for sickle cell disease is still looking very good. It's 95% for patients under 16 and 81% for patients above 16 years of age. So results are still very positive, and patients that have an unidentified donor are definitely considered for that. So what's the standard of care of treatment for sickle cell disease, and what can they accomplish? And I'm going to talk about these 4 drugs mainly. Hydroxyurea is definitely the oldest one. It's a ribonucleotide reductase inhibitor, and it has been recognized to have several different mechanisms. It's almost like it was meant to treat sickle cell disease, really, because it will induce fetal hemoglobin that will block sickling. It will lower white blood cells and platelets and reticulocyte counts, decrease cell adhesion, so definitely beneficial for vaso-occlusive crisis. And it will decrease the amount of hemolysis, and it also works as a mild nitric oxide donor. So in that scheme representing how we understand sickle cell disease, we can see that hydroxyurea can affect polymerization, can help with nitric oxide depletion, can help with cell adhesion. So it's no wonder that it was so successfully used in sickle cell disease. The multicenter study of hydroxyurea in 1995 showed that these patients had a longer time until their vaso-occlusive crisis. They would have a lower incidence of acute chest syndrome when they were on hydroxyurea, and it did reduce the need for blood transfusions. But I think what I like to highlight about the multicenter study of hydroxyurea is what people don't want to hear, is that the study itself did not show an impressive increase in hemoglobin. The average was short of 1 gram per deciliter, and the increase in fetal hemoglobin was also very modest. So I think most of what we learned about what to expect in terms of changes to these patients' lab and disease came from real life experience and not from this particular study. We will consider hydroxyurea for nearly all patients, but definitely for patients with 3 or more vaso-occlusive crises per year, acute chest, history or if they are developing chronic kidney disease, some degree of end organ damage. And what I think is most challenging sometimes is how to monitor and adjust hydroxyurea treatment. We will use a CBC with differential reticulocyte count and fetal hemoglobin levels to track how well these patients are doing on hydroxyurea. If you have availability, you might want to track F cells or F retics, and I'll talk a little bit more about that in a second, why or why not we should be doing that. But the goal is to achieve the maximum tolerated dose, which is a dose at which the patient has an ANC between 2 and 4. I personally tend to go as close or even below 2 if I can, and if the patient tolerates, because at that level of suppression, you are more likely to get the fetal hemoglobin closer to 20%. The reason why 20% is so important is because usually patients will have nearly 100% of fetal hemoglobin-rich cells, the F cells. Problems with toxicity, we will need to reduce dose depending on neutropenia, thrombocytopenia, and reticulocytopenia, but not anemia. We recognize that even if you have a hemoglobin of 5, if your marrow is still reticking, you don't necessarily need to change the dose. But the challenges with hydroxyurea are patients won't adhere to the treatment necessarily, so it is a challenge. The pills are definitely big. They're not pleasant to take. Lack of response, at least 30% of patients won't respond adequately to hydroxyurea. Intolerance and toxicity will also be part of many patients' experience with hydroxyurea. And finally, hydroxyurea only induces a heterocellular distribution of fetal hemoglobin. So while I wasn't at the NIH, we were working on a sickle imaging flow cytometry assay, trying to use that as a way to evaluate the amount of sickling. And what we found by adapting the same assay but using antibodies against fetal hemoglobin was that we were able to look at F cells and non-F cells. And as you can see on the right, let me see if I can show it with the mouse. So here you would see, you would say, this is a typical sickled cell that has very low or no fetal hemoglobin, which is expected. And similarly, you can see the cell has a lot of fetal hemoglobin and it's not sickling. But both a cell that has almost no fetal hemoglobin and a cell that is very rich in fetal hemoglobin can sickle or not sickle, not as predictably as we would like to see. So heterocellular expression of fetal hemoglobin is definitely imperfect. So that led us to develop newer treatments for sickle cell disease based on what we learned from the pathophysiology. I will talk about L-glutamine, which addresses mainly oxidative stress in sickle cell disease. I'll talk about crizanlizumab, which will address mainly cell adhesion. And finally, voxelotor, which is a newer anti-sickling medication. I'll start with L-glutamine, which was the first medication to be approved by the FDA after so many decades, only having Hydroxyurea. And this is just to show what effect we saw with L-glutamine. L-glutamine is a non-essential amino acid that will contribute to decrease the amount of oxidative stress in sickle cell patients. And as you can see from the curves, the time to the first and the second vaso-occlusive crisis will decrease significantly. We also see that overall, these patients will have a lower number of pain crises over the length of the study. What can we expect from such a treatment? First, it decreases the amount of crises from 4 to 3 crises per year. It prolongs the time to the first crisis. It will definitely decrease the amount of patients that experience acute chest syndrome. But I think the main challenge is that first, we don't have a good way of telling if the patient is responding or is even using the medication, because we learned from hydroxyurea that it was a challenge to keep patients taking chronic medication. Just so you know, L-glutamine comes in packets with the powder that has to be dissolved in water or juice. So it's a very intensive treatment on the patient's part. You have to take it twice a day, and most patients will have to take three packets. So without any lab or any way of monitoring whether the patient is taking it correctly and whether they're getting actual benefit, it's really a challenge over defining whether the patient will have benefit unless you have them taking it for maybe a year and then you decide that it was not worth it. The next one is crizanlizumab, and I'll be honest, I thought at first that the best name for this drug should be crizanlizumab because it should be lysing the crisis in sickle cell disease. But then, unfortunately, that's not what the medication does, so I'm actually glad that we didn't call it differently. Unfortunately, it does not work to stop the crisis, but it does decrease similarly the incidence of vaso-occlusive crisis. So you can see from the graphs that patients on different doses had a dose response in terms of the decrease of vaso-occlusive crisis. One thing that I also like to highlight is that, and you can probably not read this, so I'll just trust me. The amount of patients that were on hydroxyurea during the trial is about 62-63%. So all these medications were developed in the post-hydroxyurea era, and most of the studies will have at least 2/3 of patients on hydroxyurea. So we are talking about addition and not really replacement of hydroxyurea as the main therapy. Crizanlizumab is an anti-P-selectin monoclonal antibody, so it will help disrupt that relationship between endothelial cells and circulating blood cells, and even bridges that platelets are able to make between neutrophils, for example. The rate of vaso-occlusive crisis definitely decreases by about 45% in such patients. And one thing that I have to highlight is that being a parenteral infusion makes it certain that the patient is getting it. Patients come to the clinic once a month, so at least it's easier for us to define whether the patient has benefit from the medication or not. since it only affects cell adhesion, it does not change hemolysis at all. Among the challenges with crizanlizumab is, again, there's no monitoring for crizanlizumab infusions. We don't see any changes in white blood cells or hemolytic markers. But again, at least we know who is getting it, so it's less of a problem that patient about bioavailability. Our problem still is interaction with other medications. The studies have not thoroughly checked all the possible interactions, especially between these newer drugs. And we have seen rare infusion reactions. We have seen a couple in our center manifesting as a pain crisis with fever. And etiology is largely unknown. The literature is debating a lot whether this is an allergic reaction or is it antibody mediated. In our experience, at least, it sounds like it's antibody mediated because all our patients who had this reaction had it on their second dose, so it seems like you need some prior exposure to the medication to have that reaction. Finally, voxelotor is the third and newest drug to be approved for sickle cell disease. And the main effect that I want to highlight here is the effect on hemoglobin levels. So these are waterfall plots showing, so the left-hand side is the group on the highest dose of voxelotor, and you can see that most of these patients did have an increase in hemoglobin, while patients on placebo on the right-hand side did not have any significant improvement. Improvement in hemoglobin ranges from 1 to up to over 3 grams of hemoglobin, so some patients definitely have a very robust response to that. And again, I don't trust you can read it, but in this study, similarly, over 60% of patients were already on hydroxyurea, so there's definitely room for an additive effect. Also, they demonstrated quite nicely that patients on voxelotor had a reduction in reticulocytosis, in indirect bilirubin, LDH levels, and on the top right, you can see the curves showing the hemoglobin in both the placebo, low dose and high dose voxelotor groups. So it definitely induces an improvement in hemoglobin levels, and it's sustained throughout the trial. A longer-term follow-up of the same study showed that it definitely was a persistent effect on these patients, and up to almost 90% actually of patients in the long-term follow-up had some response of at least 1 gram of increase in hemoglobin. So this is definitely a drug to watch for. It has the ability to increase hemoglobin in a way that for certain patients might be the difference between being on transfusions or not. It is an anti-sickling molecule, so, and it's given once daily orally. I think the challenge for any anti-sickling drug, such as voxelotor, is the amount of hemoglobin that it's able to bind. And I will say that an occupancy rate of 26.5%, which is what they achieved, is pretty robust. It's really hard considering the billions of molecules of hemoglobin that you're trying to bind at once, and how tightly packed the hemoglobin molecules are inside the red cell. In any case, even though the response in terms of hemoglobin was really good, we didn't see that much of a response, even though there is one, decreasing sickle cell crisis. So of course, patients will be transfused less, they have less crisis. One thing that I failed to add to this slide that I'd like to mention is that in this study, some patients actually reached normal hemoglobins around 12 to 14, which has always been very scary for anyone in the field, just underscoring how good the anti-sickling mechanism is. You are able to have a normal level of hemoglobin without causing catastrophic vaso-occlusion. What did we learn from voxelotor? That blocking about 30% of hemoglobin S is probably beneficial in terms of the amount of hemolysis that you will get. We also learned that it's probably impossible to bind all the hemoglobin, so you stop sickling altogether. So they definitely hit sort of a ceiling effect with this medication. And one challenge that I also like to mention is that since it binds to hemoglobin, it will change the way the hemoglobin electrophoresis looks like. So it's really hard, and I've talked to Dan about a few patients in this regard, about how to monitor, for example, fetal hemoglobin levels in patients that are both on hydroxyurea and voxelotor. So I think we still haven't figured everything out about how to monitor these patients. We also don't know who needs the combination and who doesn't. So I think more to come. So we reached the point that everything we're doing is good, but we're really falling short of what we want to achieve. And in the next, in the last section of this talk, I want to talk about novel approaches for sickle cell disease and what we can hope for. So there are several groups of medications that I'm going to show here. First, I want to talk about novel fetal hemoglobin inducers. As you can see, hydroxyurea is good, but not perfect. Not everyone will respond or be able to take that. We want to talk a little about new molecules that can reduce cell adhesion, so further in comparison to what we achieved with crizanlizumab. Novel anti-sickling agents, and finally, agents that can also contribute to reduce endothelial cell dysfunction. For novel fetal hemoglobin inducers, it is a vast landscape of different medications, and I'm only showing like the main ones that have been under study. Decitabine and THU in combination, it's an ongoing trial. Panobinostat, which is a HiDAC inhibitor. The very interesting combination of metformin and hydroxyurea, when they uncover that metformin inhibits or induces FOXL3, which is a pathway known to induce fetal hemoglobin. So that's definitely a study we're looking forward to. Very inexpensive drug and well tolerated. And then PDE9 inhibitor, that's also another pathway that leads to fetal hemoglobin induction. That's a very large ongoing study right now. And finally, benserazide, which is a dopa decarboxylase inhibitor that was found at first in vitro to have very potent fetal hemoglobin inducing capabilities, and now translating into a clinical trial. So that's also, and the advantage being, we looked at patients that were treated for Parkinson's with benserazide, for those familiar with the drug. And it's very well tolerated for a very long time and a wide range of doses. So it does hold promise. In terms of reducing cell adhesion, I'm just going to highlight two main agents. One is inclacumab, which is a second-generation anti-P-selectin monoclonal antibody. It's undergoing phase 3 trials. So I guess the idea here is just to try to suppress P-selectin in patients who failed crizanlizumab or were unable to tolerate crizanlizumab. IVIG is definitely one of my favorites on this list, and that's just because, first, this is an ancient observation of patients who received IVIG for other reasons that got better. And second, it's been a very hard trial to pull off. I recognize this trial has been ongoing for many, many years. I'm just hopeful that they're able to enroll enough patients to give us an answer as to whether IVIG could be helpful, particularly for the setting of acute vaso-occlusive crisis. In terms of anti-sickling therapies, everybody recognized that the red cell sickling is the first step in the disease pathophysiology. So there's a range of drugs that are being tried with anti-sickling capabilities. Two of them, or actually 3 of them, are pyruvate kinase activators, and one is a more direct hemoglobin S polymerization inhibitor. They're all mostly in phase 1 at this moment, but we expect to open at least one of these trials later this year to try anti-sickling agents in our patients. And I'm just going to highlight the pyruvate kinase activation as a possible treatment for sickle cell disease, because I think it was not exactly an idea at first when they first developed these agents. So I'm representing here glycolysis and the way it happens in a red cell in sickle cell disease. So just highlighting that in sickle cell disease, it's been recognized that pyruvate kinase activity is decreased in a way that it will allow the cell to make less ATP and to defend against oxidative stress. And also, it will end up increasing the 2,3-DPG inside the cell, which essentially lowers the affinity for oxygen. For sickle cell disease, this is devastating because it stabilizes the hemoglobin in the form that will polymerize. So having a pyruvate kinase activator is actually doubly interesting. You would generate more energy for the cell to survive, and at the same time, you can also decrease 2,3-DPG and probably decrease sickling. There are 3, as I mentioned, different pyruvate kinase activators undergoing clinical trials. One of them is this FT4202. They have already demonstrated in vitro and in animal models and also in healthy and sickle cell subjects that you're able to shift the hemoglobin affinity for oxygen. So that's why this drug is now undergoing clinical trials. And finally, I just wanted to mention some agents that can help reduce endothelial dysfunction, which we understand underlies lots of the complications that patients face that lead to end organ damage. There's a lot of interest in complement inhibitors these days in several different diseases. Sickle cell disease is another one in which we recognize complement activation plays a role, even though I believe it's not a major one for daily complications we see. But crovalimab is a C5 inhibitor that's being studied in a phase 1b trial. And that's one of the ideas is to expand this further if it's well tolerated. The other medications that I need to at least touch base on are nitric oxide related. And as I mentioned, L-glutamine has been approved for the treatment of sickle cell disease, and it's a precursor of arginine, which is a precursor of nitric oxide. So arginine is being studied and has been the subject of the career of Dr. Claudia Morris at Emory for decades now. And they finally got funding for their phase 1/2 trial looking at IV infusions of high-dose arginine for sickle cell crisis. That should be a very interesting study to watch. And olinsiguat and riociguat are soluble guanylate cyclase inhibitors. They are already in use for pulmonary hypertension, but they've been recognized to be also useful to reduce endothelial dysfunction in sickle cell disease, so also clinical trials to watch for. And finally, the part of heme scavenging. We know hemolysis leads to the release of hemoglobin and heme, and a hemopaxin-based IV infusion is currently undergoing phase 1 trials. The expectation is that that would reduce endothelial dysfunction. Whether that could help abort crisis or decrease end organ damage is still unclear. I can't not mention here at UW, since so many people are interested in ADAMTS13, but recombinant ADAMTS13 is being studied in a phase 1 trial for sickle cell disease as a possibility. We know that long strands of von Willebrand factor contribute to red cell destruction in sickle cell disease. Dr. Jose Lopez, for example, has well demonstrated that in vitro. So I think it's something that might help certain complications in sickle cell disease. Still unclear what the actual clinical indication would be, but definitely an interesting drug to watch for. So this is mainly a summary of where I think all these medications that I've just mentioned might fall into. So it might expand our portfolio of medications to treat sickle cell disease quite dramatically. Of course, I don't think all of these drugs will be successful, and only time will tell which of those will actually make it into the clinic. In my last few minutes, I want to touch base on gene therapy because I can't help but do it. Gene therapy is regarded as the next big promise to cure sickle cell disease, and the number of ways you can use gene therapy to cure sickle cell disease grows every day. We can add a new hemoglobin, you can add an anti-sickling hemoglobin or just a different hemoglobin A. You can try to correct the mutation. You can also try to interfere with fetal hemoglobin induction in several different ways. I think everyone probably saw this paper at some point, which is the first report of successful gene therapy in a patient with sickle cell disease. And again, I share the same excitement that Dr. Adan Sabath was talking about when you see for the very first time someone who is able to make an anti-sickling hemoglobin delivered through gene therapy. I think we can see that sickled cells in vitro in this particular patient, they were very much diminished after gene therapy, but they still look a lot like the patient's mother who carries sickle cell trait. So again, we still don't know if gene therapy, the way it's being tried right now, will lead to cure or it will lead to just a very mild form of sickle cell disease. Similarly, CRISPR-Cas9 gene editing tools have been under study for gene therapy. And similarly, what changes here is how you're approaching, how you want to fix sickle cell disease. For the most popular CRISPR-Cas9 gene therapy that we have results from, it's all about disrupting BCL11A signaling. That will lead to a form of pancellular hereditary persistence of fetal hemoglobin. So again, we know that sickle HPFH is not perfect, but it's most likely much better tolerated and will most likely not affect the patient's lifespan moving forward. There are pros and cons when we talk about curing sickle cell disease because we have to compare gene therapy with allogeneic transplant, which has already been proved to be successful. And I think allogeneic transplant has the benefit of having come first. The problem is we still don't have a good hand on GVHD, on immune suppression, and long-term effects of the conditioning regimens, both radiation and chemotherapy. On the other hand, gene therapy, of course, it's new and we'll learn more as we go, but we still worry about off-target effects. And we've heard a lot of reports concerning for development of MDS and AML, and it's unclear still what's driving the development of these complications. So I think more to come. We can't deny that gene therapy expands the possibility of a transplant and cure to nearly all patients with sickle cell disease. With that, I'd like to leave you with this very busy figure, just showing all the things that we have, all the things that are still under development that we can try to use for sickle cell disease, and how, even though we've known for decades now how this disease happens and all the intricacies of the pathophysiology, still, by even blocking all steps of this pathophysiology, we still haven't successfully been able to control it the way we would like. And with that, I would like to end this talk. These are my acknowledgments. I very much appreciate the invitation to give this, this talk, and I hope we have some time for questions.
Just, Kleber, having looked at a few of the patients that we do like HPLC on, for example, on voxelotor, I think actually it's pretty reasonable. I think we can quantify the various hemoglobins pretty well, that basically you get these doublets, and as long as we're aware that they're there, I think we should be able to do some reasonable quantification for those. So I think that's definitely doable. I think you've seen some of our HPLC tracings too, right?
Yes. So I think it's possible to quantify fairly accurately once you have, once you have experience with such samples. I think what we don't know yet is how much long-term the fact that you're changing the affinity for oxygen will change the effect of hydroxyurea on the marrow. I think my main concern when I have patients on both drugs is that we know hydroxyurea and any fetal hemoglobin inducer will only work under stress erythropoiesis. So I wonder how much, if it could or could not change the way the marrow behaves. So far, I think I haven't seen any patient have a drop in fetal hemoglobin response that we can't attribute to just binding of voxelotor to fetal hemoglobin. So I think but one thing that maybe we'll have to move forward with is changing the way we look at those samples and report those samples. Otherwise, we get caught in. It's similar to what happened when people would try to report hemoglobin A1C in patients that, for example, have some hemoglobin A but have a hemoglobinopathy. It's not reliable, and then you're talking about this peak and you're ignoring the other peaks. So it might get more granular for us to understand how much fetal hemoglobin the patient's really making.
Actually, that reminds me of another question. So some patients respond very well to hydroxyurea, and others have really minimal, if any, response. Do you want to comment on why you think there's such a variable response to hydroxyurea from one patient to another?
Yeah, that's a great question. We know that genetic polymorphisms influence the response to hydroxyurea. So of course, if we know that a patient has, for example, an XMN1 polymorphism, they're very likely to first have a baseline fetal hemoglobin that's quite high and will respond quite well to hydroxyurea. We also see patients who don't carry that who respond, and we are not completely certain why that is. There are other loci that regulate fetal hemoglobin expression, so that's definitely an area of interest. The other thing is about, again, the amount of stress erythropoiesis. So we've been able to improve patients' response by adding EPO, for example, in the past. Problem with EPO being patients normally don't want to be on a subcutaneous injection. It does carry some risk, some increased risk in clotting. So I think, but still showing that if you modify certain aspects of the erythropoiesis, you're able to enhance that. Unfortunately, some patients just won't respond. And it takes time to know if the patient will really not respond. Unless, of course, they have toxicity. If they develop neutropenia, you know they've had enough hydroxyurea and it's just not responding.
Thanks. So Andy Hoofnagel asks, any idea what the mechanism behind P-selectin expression on endothelial cells in hemoglobin S disease?
So, great question. I don't have a good understanding of why exactly we have that increased, that expression per se. I can tell you that endothelial dysfunction does associate with a higher expression of P-selectin on the endothelial cells. And I think it's almost, how can I say that? We understand that endothelial cells are chronically exposed to cytokines, heme, free hemoglobin, and particularly the interaction with toll-like receptors on endothelial cells, for example, triggers a certain cascade of events in the endothelial cell that will activate that cell to express that. But why exactly P-selectin is more important than E-selectin and other adhesion molecules is unclear. I know in vitro and animal studies have looked a lot at all sorts of cell adhesion molecules before P-selectin was demonstrated to be more important. But yeah, to me, maybe it's signaling to us that platelets are more important to the pathophysiology than we like to think. Especially because we have pan-selectin inhibitors that have been tried in sickle cell disease, and they did not necessarily have a better response. So inhibiting more adhesion molecules doesn't seem to be very useful.
We have two more online questions. One from Naviha. She says, thanks for your talk. I'm wondering how you counsel your patients regarding various clinical trials, especially stem cell transplant versus gene therapy.
Great question. And I think it's been a big focus of my clinic, trying to figure out how to approach patients about that. So for starters, this is a congenital disease, so all patients that come to me have been seeing their pediatricians for almost 2 decades, and they have most likely discussed indication for a transplant earlier in life. So when they come to our clinic, that's their chance to revisit that because their parents made the decision, for example, to not transplant, for example. Or sometimes they didn't have a donor. So that's the most frequent scenario. But sometimes they did have a donor, but the parents decided not to transplant. And then when you revisit that, you're looking at how they see their lifespan, right? Again, that's why it's so important to understand, even with the best care possible, you're probably missing out on 20 years of your life. You will probably struggle with a lot of complications later on. So it's hard to approach when a patient is very successful at their therapy. So I get patients that fortunately respond very well to hydroxyurea. They have a very good life. They very rarely go to the hospital. Those are great. And then it's hard sometimes to explain what benefit they would have. And it's debatable. I think those are the tough cases. But when the patient is all the time in the hospital, I think it's easier to approach the question about transplant. And then transplant versus gene therapy. Interestingly, all patients come to me asking about gene therapy. And then I explain how it works. And then they're like, wait, so it's a transplant? Because you get chemotherapy and then you get the cells infused. Like, yes, it's an auto transplant, but it's still a transplant. And that's when sometimes you go back and say, wait, so have you ever looked whether you have a donor? Because we have more data on allogeneic transplant than we have for gene therapy. So sometimes it goes back and forth. I think that's pretty much how I'm trying to approach it.
Last question online. Why do you think it's been so difficult to enroll an IVIG trial since it's been given for multiple other indications and patients are used to getting transfusions?
Yeah, I think there are some complexities to that trial specifically. First, it's a single center. So of course, you rely on the patients that you get at your center only. The second thing is, in any trial looking at treating patients with vaso-occlusive crisis has such a wide heterogeneity of cases that it's, depending on how strict you are about your inclusion criteria, it's really hard to enroll patients. At the same time, if you are too broad, then you're treating people with very different diseases. So I think that has been the biggest struggle trying to enroll patients. And that will be true, I think, for any medication to treat sickle cell crisis, because no one wants to invest millions and have the drug fail, but then you're trying to narrow it down to like the sickest patients. Only the sickest patients also have all the comorbidities that prevent the drug from being successful. You might miss that signal.
Do any of the new treatments work in combination with hydroxyurea?
So you mean the FDA-approved ones? They were all tried on patients that were on hydroxyurea as well.
Any of the new ones that are?
So the new ones, I think those three first medications set the stage for everyone else. So everyone already has the expectation that you're going to enroll patients that may be on hydroxyurea because it is standard of care. It's really hard to randomize hydroxyurea versus something at this point because it's so well tolerated. And I think we're still looking for things to add to hydroxyurea as the backbone of the treatment. So most of these studies, they do not discriminate. I think they discriminate among themselves. So for example, the anti-sickling agents definitely can't enroll patients who are already on voxelotor, an anti-sickling agent. Same thing for the anti-p-selectin and new anti-p-selectin inhibitors. You can't enroll overlapping medications. So that's going to be a challenge also moving forward.
Thanks, Dr. Fertrin. It's been great.
All right, thanks, Kleber.
Thanks, everyone.